infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Now, according to the American Cancer Society annual report, in 2017, there will be an estimated 1.7 million new cancer cases diagnosed and more than 600,000 cancer deaths in the U.S. Of this total, 250,000 breast cancer diagnoses and 40,000 deaths are estimated in U.S. women in 2017. Easily the most common cancer reported in women, accounting for nearly a third of all cancers in women. Well, joining me now to discuss breast cancer is J. Leonard Lichtenfeld, MD. Dr. Lichtenfeld is the Deputy Chief Medical Officer for the American Cancer Society. Dr. Lichtenfeld, welcome to the show, sir.
Hello, it's a pleasure to be with you.
Yes, sir. Well, let's go ahead and start with the most elementary type question and give us a little summary of what is breast cancer.
Well, simply stated, breast cancer is a cancer malignant growth that occurs in the tissues of the breast. And there are several different kinds of tissues, although the most common form of breast cancer occurs in the milk ducts and is called ductal or intraductal carcinoma. But there are also supporting structure tissues in the breast, and sometimes the cancer can start there as well. But they are clearly less common than the most typical type, which is generally referred to as intraductal carcinoma.
Now, what are the general signs of breast cancer?
Well, we actually, when we talk about signs, we're usually talking about things that people can find, that people think they can see. So our hope is that we can find breast cancer before we see a sign of it. But there's still many situations where a woman can, even if she has mammograms done on a regular basis, breast cancer can still occur in between. So anytime you notice, frankly, a change in the breast, so women need to be sensitive to how their breasts feel normally. And if they feel new lumps or an abnormality, then that's something they should get checked out. Now, some women may be more prone, for example, to having cystic changes, and they get to know that over time, and they can feel what's typical and what's not typical. But if something is there and it's firm and it's hard and it's changing in size, then that's something to be concerned about. Another sign that can occur is what we call nipple inversion. That is a change in the appearance of the nipple and, frankly, an inversion, a sinking in of the nipple, if you would. And sometimes women can get inflammation-like changes on the skin of the breast, and that can be a sign of what we call inflammatory breast cancer. And there are a lot of other situations that can happen. So a woman might not feel a lesion in the breast, but feel a change in a lymph node or swelling under the arm, or sometimes even in the neck. Anytime a woman notices a change that's of concern to her in the area around the breast, it never hurts to go see a health professional and say, is this something I need to be concerned about? As I mentioned, that's a good idea a good recommendation for women to remember. Even if they had a mammogram done, sometimes a couple of weeks, that's not common, fortunately, but even a couple of months ago, they should not just pass it off and say it doesn't mean anything. They should go get it checked.
Right, and you're saying that these signs, that's at a point where they should have already been caught with mammograms and other methodologies.
Well, yes, for most women, but we need to remind everyone that mammograms don't catch every breast cancer. And again, even if they're done regularly every year, sometimes a breast cancer can grow in between a mammogram. Mm-hmm. Sometimes a breast cancer can occur before a woman starts getting mammograms, before the age of 40 or 45, or 50, depending on what recommendation one chooses to follow. Even for women in their 20s or 30s, if they notice some of these changes, don't think because you're that young, and 20, it's obviously very uncommon, fortunately, but when you're in your 30s and you notice one of these changes, that's some time you should go see a health professional. Remember, it never hurts to go ask. That's right. So what's the worst that can happen? You go and you see your whoever provides your regular health care, your doctor, PA, nurse, whatever. You go in and see them. What's the worst that can happen? They say, we don't think this is anything. We'll check it out. It turns out to be nothing. That's not a problem. But ignoring it and letting things happen, no, that's not a good idea.
Yeah, great advice. Is this inherited? Is there a genetic component to breast cancer?
Well, for some women, the answer is clearly yes. Now, it's a smaller minority of breast cancers, maybe on the order of 10, 12% when we consider all the genetic abnormalities. So there are some women who have family histories that are strongly suggestive of a genetic syndrome such as what we call BRCA. That's a particular gene that can be changed in a way that increases one's risk of getting breast cancer and also increases the risk of getting it in a younger age. And that can also apply to ovarian cancer. But besides BRCA, there are other genetic abnormalities. Some of them are much less common. What's interesting is that more recently, our tools and our ability to look at the genome, look at our genes, those tools have gotten a lot more available. And what's been interesting, unfortunately, is we're finding a lot more genetically based cancers than we were aware of in the past, not just in breast, but in other cancers as well. Mm-hmm. But having said that, if you have a family history, a strong family history of multiple people in your family, particularly at a young age, or ovarian cancer in your family, once again, it's a good idea to talk to your health professional about the possibility of having one of these genetic syndromes that put you at greater risk, and you may need to get genetic counseling and get tested to see whether or not you have a predisposition to developing breast or, in fact, other cancers as well.
Just to piggyback on that, so other than genetics, what other risk factors would you be concerned about?
Well, there are a whole list of them, and I would suggest if people are interested in getting more information, they go to our website at cancer.org, or they can call us. We have a call center that's available 24/7 at 800-227-2345. That's 800-227-2345, and can find out what the various risk factors are. There are a whole list of them, and it has to do with pregnancies and timing of the first pregnancy, when you started to have your periods, how long you had your periods. There are calculators available online where you can go and put in all the information about you, your personal history, your family history, and determine whether or not you're at higher risk of getting breast cancer.
Excellent. I'll go ahead and post all that stuff on the website. Now, let's go over some terms. Doctors use the term cancer grade to discuss the seriousness of the cancer. What does the cancer grade mean?
Well, as we're learning recently, there are a lot of factors that can help us look and predict how aggressive a cancer may be. And in the past, grade was one of the primary ways we could do that. Now we have other tests that help us be even more specific than what the grade is. Having said that, simply stated, what the grade of the cancer is when the doctor looks at the breast cancer under a microscope, how aggressive the cells appear to be. The closer they are to normal breast cells, then the lower the grade, the more unlike or dislike, more different they appear than typical breast cells, the higher the grade. And the higher the grade, the greater the risk that cancer can be more serious.
And how does this differ from cancer stage?
Well, cancer stage is a different concept. Grade refers to how the cells look under the microscope. Mm-hmm. Stage refers to what's the size of the cancer, how far has it spread, and has it spread to other parts of the body. So in some situations, for example, in what some people call stage 0 or ductal carcinoma in situ, that's a cancer that's not invasive, and generally not in every case, but in almost all cases, that's a tumor that's removed and can frequently not cause any further problems. Some experts, as a matter of fact, don't even think that stage 0 or DCIS should be called cancer in the first place. And then you move up the ladder, so to speak. And as the tumor gets bigger, as it spreads to the lymph nodes, as it spreads to other parts of the body, that stage increases. So a larger cancer in the breast might be a stage 2 cancer. If the lymph nodes are involved, it can become a stage 3 cancer. And if it spreads to other parts of the body, then whether that be the lung or the liver or the bone, it's a stage 4 cancer at the time it's diagnosed.
Okay. Now, there's a number of treatment options. What are some of these options? Some of them are very common, most people know about. And does the cancer stage affect these options available? Which ones you would choose?
Well, we need to bear in mind that there are four basic kinds of cancer treatment. One is surgery. The other is using chemotherapy, drug therapies, and radiation therapy. So most people are familiar with that. And now we have immunotherapies that have come on the scene, and they may have some role. They don't have as big a role in breast cancer today as they do in other cancers. But, most people are familiar with chemotherapy. That's the more traditional drugs that are given intravenously. Some are given by mouth. There are also drugs that are taken by mouth that affect the production of estrogen in the body, what we call anti-estrogens, and drugs like anastrozole, letrozole can be used. There are targeted therapies, and targeted therapies are drugs that are what we call biologics that actually attack the mechanism of the cancer cell. And a number of years ago at this point, it's been about 15 years, we've been using a drug like Herceptin in women who have a genetic abnormality, what we call HER2 in breast cancer. So those drugs can be used in women who have HER2-positive breast cancer. Radiation therapy would be used sometimes for treating localized disease. It may be given if somebody has a lumpectomy, for example, with just the cancer's taken out of the breast, the rest of the breast is treated. Sometimes radiation is used to treat areas around the breast if the cancer is more extensive. Basically, still local or regional radiation therapy. And, of course, radiation can be used to treat the disease if it's spread elsewhere as symptomatic, such as it might occur with a lesion that goes to the bone.
Now, what are some of the risks and, well, obviously the benefits are they get better, but what are some of the risks to some of these treatments?
Well, there are obviously a lot of risks. I mean, the typical ones, nausea, depending on the drug, nausea, vomiting, hair loss, decrease in blood counts, fevers. Those are, again, that's information you can find in detail on our website at cancer.org. And, of course, if you're going to be getting any of these treatments, it's very important you talk to your oncology care team to get a full understanding of what the risks are for your particular treatment. Unfortunately, or maybe fortunately, there's so many different treatments available today that it's very difficult to say this is a concise catalog of all the things that could happen to you. So if you take what we call these the anti-estrogen aromatase inhibitors, if you take a drug like that, then you have to be concerned about hot flashes and the possibility of some drugs of causing early menopause. I mean, there are all sorts of things that can happen, unfortunately. Some of them are reversible and some are not, and it's very important you have a full understanding. I think that's the most important message. Your care team should provide you with a full list and a full explanation of what may happen to you. One particularly difficult problem can be what we call neuropathy that occurs in some women who are treated for breast cancer. It occurs more frequently in other cancers, but you can get treatment changes in the nervous system that can lead to numbness in the extremities, and that can be very problematic, sometimes reversible and sometimes not.
Now, obviously some women have a lot of concerns about mastectomies and the chemo. As a physician, how do you address these concerns with a patient?
I think it's very important that you and your care team and of course your physicians, the leader of that team, have a discussion about what your needs and your wishes and your goals are. And those may differ depending on where you are in your journey with breast cancer or any other cancer for that matter. Right. So if you have that discussion, then you can make your feelings known. And I think that's the point I'm trying to make here is that you need to understand as a patient that you have to have the information that makes you comfortable receiving your treatment. And if you don't get that information, then you need to ask. And it's not just the doctor who has that. Your care team, the nurses are wonderful. And they're right. In fact, going through chemotherapy, sometimes they're one of the most, if not the most important support that you're going to have. If you have a question, ask. Make sure you get an answer. Make sure you get the answer you get is the answer you need for you to understand what's happening during the course of your treatment.
Excellent. Now, what are the risks of breast cancer metastasizing or reoccurring?
That really depends on a lot of factors. And what we're learning and what we've learned recently, I mentioned earlier in this discussion, was we have the opportunity now to go way beyond just the grade and the stage to tell us about a breast cancer. We can actually take the sample of tissue and look at it for what we call genomic markers. And those markers can tell us things that we don't see under the microscope. So sometimes you may have a cancer that looks aggressive under the microscope, or it may be larger, or it can even involve the lymph nodes. And yet research has recently shown us that those tumors may not require very intensive therapy. So those studies have been done. And then there are other occasions where you may have a very small cancer. Something is found, the doctor says, I'm so glad you came in, we found it early. But when the markers are done, they show that it's more aggressive. And those women, more intensive treatment is warranted. So it's really a matter of seeing someone who knows about breast cancer, who's treated breast cancer, who knows the tests that have to be done, who can help you understand the results of that test, and allowing the information that we can put together guide your treatment. There's some new, what we call this. You mentioned stage earlier. We talked about how we stage cancer. There's some new guidelines coming out about staging that have really moved in the direction of looking carefully at the biology of the tumor. That is, what's this cancer like, as opposed to trying to have big buckets that may, we used to put people in. We said they're estrogen receptor positive or negative, or the grade we mentioned earlier. Right. Now we can sort of become much more focused on what that cancer is telling us about the treatment that a woman needs. And frankly, what we're seeing is that we can, even in some women, there's been some reports recently, but in some women where we can, in early stage breast cancer, just take the cancer out and give the radiation and not do anything further. And it doesn't apply to all women, but for those women who don't have to get further treatment, which may last for 5, 10, or 15 years, that's a good thing.
Now, is there a definite point when a person is actually considered cancer-free? Does such a thing exist?
Well, the answer is we actually have tests now in certain cancers that can tell us if someone is cancer-free or has no detectable evidence of cancer at a very, very small level, really getting down to what we call the molecular level. Mm-hmm. In breast cancer, we are not there at this point in time. And the problem with breast cancer, unfortunately, is that, or fortunately, I guess, that many women can be treated and never have another problem with breast cancer the rest of their lives. But unfortunately, there are still a small subset of women, even if they have early cancers, who the cancer can recur 10 or even 15 years later. We're developing the tools to help us not only monitor what the original breast cancer is telling us, but there are actually some very interesting research studies underway which look at blood samples that are able to predict when a cancer is recurring. So this is all changing as we speak, and I literally mean that as we speak. I mean, from one day to the next or 1 year to the next, there's a lot of progress. So there may come a day in breast cancer where we get to the point where we say somebody is cancer-free, but we're not there yet. Although, fortunately, most women with breast cancer, particularly if it's caught early on, most women, almost all women, do well, and that's the good news part of the story.
Yeah. I got about 4 minutes left. So what do you tell patients about genetic testing for the BRCA mutations? Is this something that is required for everybody or suggested for anybody, or how does that work?
Well, as I mentioned earlier on, there are familial syndromes, and BRCA is certainly one of them, and it applies at the largest level for women with breast and ovarian cancer, but it can apply to men with prostate cancer and pancreatic cancer and other cancers as well. So it's not just breast cancer. So that's why it's really important for everyone to know their family history about cancer, not just their mom and their dad, but their aunts, their uncles, their cousins, their grandparents. They should have that information. They should have it available. And there are some experts who do believe that everybody should have a BRCA test. That is not yet the standard here in the United States. There are concerns that there are concerns about patient protection and patient privacy. But clearly, if you have a family history that has a lot of breast cancer or has ovarian cancer or has cancer at an early age, then it's a good idea to talk to a health professional about your family history and see if you need to get genetic counseling. And the genetic counselor can help sort through those issues and determine which is the right genetic test for you and whether you need one in the first place. And understand it may not just be BRCA. There are other cancer syndromes to which the genetic counselor may say, your history suggests that we get these particular tests. It may include BRCA. It may not. I will say that over time, BRCA testing has become much more available. There are what we call consumer-directed tests. That is, you don't have to necessarily. You still need an order from a health professional, but you can go pretty much your own direction to go get that test. But I think over time, we as a society are going to. We're going to be discussing this for a number of years. The day may come when we do routine genetic testing. We may get to the point where, as newborns, we do that testing to find not only BRCA, but the other genetic syndromes that can occur.
Interesting. Well, as Dr. Lichtenfeld mentioned, we can get more information at cancer.org. And the American Cancer Society also puts out a very good informational Q&A book. It's called Breast Cancer Clear and Simple. And I encourage listeners to check that out. And I want to thank you, Dr. J. Leonard Lichtenfeld, for your time and expertise. It was very informative, sir. Thank you.
Thank you. It's been a pleasure.